Hello students, welcome to EPG Pathshala. I am Rashmi Sinha from Indira Gandhi National Open University. Today, we will study the module Prevalence of Common and Rare Diseases from the paper Physiology and Sports Anthropology. The objectives of this study are, we will be able to know the definition and prevalent common diseases in India. We will also understand the study design, importance of formulating aims, defining outcome and selection of target population. We will also able to calculate the sample size and sampling methods for selection of sampling units. You will also be able to appreciate the importance of response rate, bias, odds ratio and presenting the data, and also know the magnitude, causes, definition and source of estimating prevalence of rare diseases. Aims formulation, definition of outcome and selection of target population. Before commencing the study, aims of the study have to be defined. The disease condition and risk factor should also be clearly defined, like how the disease condition is confirmed and risk factor presence is established. For example, in a cross-section studies, the presence of coronary heart diseases is confirmed by the presence of history, positive response to Rose questionnaire and Minnesota codes in electrocardiogram. Risk factors presence like hypertension is determined by measuring the individual subject blood pressure by sphygmomanometer. The target population should be selected. For example, if smoking prevalence is intended to study in Delhi, the population of Delhi becomes the target population. Target population can also be defined based on age, sex, language, ethnicity, income and residency. For the practical reasons, that is the finance, manpower or transportation, source population can be selected if the selected population is small. If the source population is too large for practical reasons, then representative population can be selected. It is also essential to set out inclusion and exclusion criteria for the subjects. Adequate sample size is essential for testing the hypothesis and drawing meaningful conclusions and to estimate the prevalence with precision. Sample size calculation. Sample size can be calculated using either power-based approach or confidence interval width. For the purpose of understanding sample size calculation using both approaches is illustrated using information cited in literature. Definition and common diseases found in India. Common diseases can be defined as those diseases which are prevalent in the community or a country. They can be communicable or non-communicable. The most commonly found infectious diseases in India are malaria, tuberculosis, HIV, cholera, plague, diphtheria, encephalitis, chikungunya, fever, swine flu and Crimean Congo, hemorrhagic fever, and the common non-communicable diseases reported in India include cardiovascular diseases, chronic obstructive pulmonary diseases, cancer, diabetes, and road traffic injuries. Study design used in prevalence studies. Now let's see them. Prevalence of common diseases is investigated using cross-sectional study design. Subjects in particular population are assessed at a point of time for the presence of a disease or the risk factors associated with disease. Prevalence can influence the physician on the likelihood of any diagnosis and the predictive value of any investigation. For example, in case of ascending cholangitis, a rare condition in children, the informed physician can look for other causes of abdominal pain in children. Cross-sectional studies are quick, easy, inexpensive, useful to screen and generate hypotheses to determine the prevalence of a disease and to plan public health. Limitations of a cross-sectional studies are not useful for knowing the cause of the disease. They are not even good for the studies of rare diseases. Sampling methods. Data on sampling frame, that is the members of the population to be recruited, can be collected using census data or electoral lists. These sources suffer from limitations. If the study intended to study children, the details of them cannot be found in the electoral list. The data on migrants or immigrants cannot be found in either of the sources. Sampling unit can be individual house or hospital. Eligible unit or subjects for the study can be recruited using sampling methods. They are of two types, non-random and random. The non-random methods are classified into three groups. They are the purposive sampling, convenience sampling, and snowballing sampling. In purposive sampling, again, specific subjects are identified and recruited. For example, smokers and epilepsy patients. Easily available subjects are recruited in the study, they are the volunteers. In snowballing sampling method, as the survey progresses, the subjects are included and they are requested to recommend others to participate in the study. In all these methods, there is always a chance of finding sampling bias. Random sampling methods ensures that each eligible subject has no chance to be included in the study. These sampling methods can be categorized into simple random sampling, systematic random sampling, stratified random sampling, cluster random sampling, and multi-stage random sampling. In simple random sampling, units, that is the individuals or household or families, are defined and required number of units will be recruited for the study. Random numbers tables can be used for this purpose. This kind of sampling is useful for small population. Whereas in systematic sampling, the units are arranged in convenient sequence and what fraction of sequence is to be recruited is decided. The sampling is done using odd number 2, 5, 7, 9. For example, every second house or the fifth can be included in the study. The main advantage of this method is of convenience. The sample of study is divided into strata, which is the subgroups. It can be based on age, sex, occupation, or socioeconomic status. In each stratum, the sampling unit is drawn by random sampling. This type of sampling is useful when specific trends are expected in terms of age, socioeconomic status, or gender. In cluster sampling, the sampling frame is divided into affiliated units or clusters. For example, if Hyderabad is the sampling frame, all municipal wards are clusters. In each cluster, sampling unit is selected either by using simple or systematic random simple sampling method. The limitation of this sampling is that in many situations, clusters are formed by homogeneous individuals than the population as a whole. In case of multi-stage sampling, sampling units are recruited based on hierarchy. For example, a sample of neighborhoods, then a sample of households, then a sample of individuals, or multi-phase sampling involving screening of individuals and selection of subsets with known probability for intense assessment. Non-response rate. Large non-response can mislead and represent only those who participated in the study. If non-response rate is influenced by variable affecting the objectives, can cause selection bias and estimates that deviate from population values. The threshold for acceptability of non-response is 70% when there is evidence of similarity in socio-demographic characteristics between respondent and non-respondent or the study population and the target population. In the absence of evidence, 80% is considered as acceptable. To encourage non-respondents, home visits can be made and a small random sample from non-respondents can show the extent of bias among non-respondents. Availability of some information on subjects in the study may be helpful in comparing the respondents against non-respondents with respect to age, sex, and socioeconomic status. Bias. Bias may be defined as the lack of internal validity or incorrect assessment of the association between an exposure and an effect in the target population. Bias was classified into three groups, namely selection bias, information bias, and confounding bias. Selection bias can be introduced into the study when samples are not representative of the target population and can be controlled by measuring the variable influencing the selection on all subjects, and when they are antecedents of both exposure and outcome. The joint distribution of these variables is known in target population, and the selection probabilities are known for each level of these variables. This bias can be introduced anytime in the study. Information bias can occur at the stage of data collection and is of three types, that is, misclassification bias, ecological fallacy, and regression to the mean. The misclassification bias can occur when the sensitivity and specificity procedure fails to detect correctly the exposure and effect. Ecological fallacy bias introduced when results in ecological analysis are applied to the individual. And regression to the mean bias is applicable when the change in variable status, that is serum glucose, and comparison is expected between the two variables. Confounding bias happens when a variable is at a risk for an effect among non-exposed persons and is associated with the exposure of interest without being affected by the exposure or the disease. Odds ratio. Using odds ratio, the strength association between putative risk factor and outcome is assessed. In prevalence studies, the cases and control are defined during the analysis. It is also possible to define cutoffs of the quantitative variable if found associated with outcome for the population under study. Presentation of data. Prevalence estimates are expressed in percent for 1,000 people or 100,000 people. Prevalence data with confidence level should be presented. Confidence interval, mostly 95%, informs that the unobserved target population value will fall within a certain range of the observed sample value. The prevalence data can be age standardized to country or world population to facilitate comparison of prevalence estimates between population or across time periods. A standard population is one for which the number in each age and sex groups are known. For age standardization, many methods are used like direct and indirect standardization, the geometric mean, equivalent average death rates, life table rates, Yerushalmi's index, cumulative death rates, absolute probabilities of death, and the comparative mortality index. The direct standardization is widely used for age standardization. Magnitude, etiology, and definition of rare diseases. Rare diseases have been shown to have impact on health of the community in terms of the related impairments, long-term disabilities, and shorter life expectancy, as well as high human and social costs. It is estimated that about 6,000 to 8,000 rare diseases are known to exist. The prevalence of rare diseases in European countries were reported as 6 to 8%. In India, the reported prevalence of rare diseases was 1 in 2,497 newborns. Rare diseases can affect all age groups, mostly identified at birth or at early age. They can present as fatal, chronic, acute, debilitating, and life-threatening conditions. The cause of the rare diseases range from genetic, infection, toxic agents, epigenetic, nutritional deficiency, and injuries. As of now, there is no consequence on the definition of rare diseases. Different organizations and countries have defined the rare diseases using different cutoff number. European Union and European Medicine Agency defines rare disease as those diseases occurring in frequency in less than 5 in a population of 10,000. In Japan, occurring not more than 4 per 10,000, and in USA, 1 in the population of 200,000. The general population is considered as the denominator. Prevalence of rare diseases may be expressed as number or proportion per live births or since days after birth and first year of life. It is recommended that while expressing prevalence at birth, the case fatality should be taken into consideration. Problems encountered in rare diseases research. The twin problems confronting the research and management of rare diseases are lack of disease-specific code in international classification of diseases and clearly defined diagnostic criteria. For each disease condition, an international classification of diseases is used which is coordinated by World Health Organization. At present, 10th version of ICD is in use. By using this version, only 300 specific rare diseases can be identified. A draft proposing improved coding for rare diseases prepared by World Health Organization Advisory Group is in circulation for comments to be finalized by the end of the 2015. By using the proposed coding, it is expected that at least 1,000 specific rare diseases can be identified. At present, classification of rare diseases proposed by systematized nomenclature of medicine, online Mendelian inheritance in man, medical subjects headings, and the orphanet's own internal codes are also in usage. Prevalence of rare diseases was mostly focused on congenital anomalies due to cost intensity and limited utility. Epidemiology in rare diseases. Epidemiology is the study of the distribution, determinants, and control of health-related states and events in population. It attempts to identify the factors responsible for the development of disease and attempts to improve the health status and quality of life in target population. Epidemiology data is useful to support an orphan designation, to the approved drug, estimate disease burden, allocation of resources for the research and management of rare diseases, and propose methods for analyzing risk and prognostic factors, drug efficacy and efficiency, and social modifiers of disease. Prevalence is a probability that an individual in a population will be a case at a time. Prevalence data in case of rare diseases are cost-effective, can be measured repeatedly, and the data is useful for long period. Sources for the estimation of prevalence in rare disease. Prevalence for rare diseases can be estimated for various sources like case reports, birth or death certificates, insurance claims, administrative databases, patients registries, special surveillance studies, biobanks, genetic test registries, and newborn screening programs. A case report may be defined as the publication in the medical scientific literature of a single clinical observation whose principal purpose is to generate hypotheses regarding human disease or provide insights into clinical practice. It is the case report which first report new rare disease as a single case or group of cases. Case reports are also useful in understanding of etiology, pathogenesis, natural history, treatment of particularly rare disease, and training of potential junior investigators. Rare diseases reported from European population data of 1400 were drawn from case reports of individuals or families. Birth and death certificates. Prevalence of rare diseases can be estimated from the birth or death certificates, birth defect, and administrative database. It has been estimated that 7.9 million births occur with defects annually in the world, and in India, the reported prevalence was 61 to 69 per thousand live births. The birth defects include congenital heart defects, neural tube defects, Down syndrome, hemoglobinopathies, and glucose 6-phosphate deficiencies. The most prevalent rare disease in the erstwhile state of Andhra Pradesh was as follows: congenital hypothyroidism, that was 1 in 1700, congenital adrenal hyperplasia, 1 in 2575, and hyperhomocystemia, it was 1 in 100. In Rohtak, Haryana, the prevalence of 16.4 thousand newborn baby anencephaly, talipes, equinovarus, and meningomyelitis seal were the most frequent congenital malformations reported in that study. In Wardha, Maharashtra, 27.2% prevalence of congenital malformation was reported per 1,000 newborn. Using hospital data, Sarkar et al. Found have reported 2.2 prevalence of congenital malformation and predominant reported systems involved were musculoskeletal system, gastrointestinal, and talipes. Using administrative hospitalization data, the prevalence of rare diseases can be calculated. This method is quick and cost-effective. The accuracy of this data depends on the identification of patient and disease-specific coding. Ward in 2005 has reported prevalence of hemophilia, multiple sclerosis, Crohn's disease, cystic fibrosis, and scleroderma per 100,000 population using hospitalization database from California. Health insurance claims can also be the source for estimating the prevalence of rare diseases. Presence of rare disease can be issue for accessing and increasing the premium for health insurance. Gross and co-workers in 2014 have reported 0.3 prevalence of hereditary hemorrhagic telangiectasia, which is characterized by the development of vascular malformation with direct artery to vein connection and loss of intervening capillaries per 10,000 persons using United States health insurance data. Patient registries. Patient registry is an organized program for the collection, storage, retrieval, and dissemination of a clearly defined set of data collected on identifiable individuals for a specific and specified purpose, as well as the collected data. In the registry, data on disease, exposure, and patient characteristics are included. Registries are an important source for estimation of prevalence of rare diseases. Registries were managed earlier by governments, and now patient-driven organizations are also involved. Registries can be classified based on data sources, which can be local or regional hospital, population based, or by the database or data characteristics, or by purpose that could be clinical or research. Apart from estimation of prevalence of rare diseases, registries can be used for the purpose like public health, health service research, health promotion, patient care, clinical research, and public safety. Qualitative assessment of registries can be done by evaluating completeness of case ascertainment, validity of values for each data point, and timeliness of data. The capture-recapture methodology is used for deciding the completeness of case ascertainment. In this method, cases are identified by various sources, be it physician or hospital data, to avoid duplication of data. Population size with particular disease is identified, missed cases estimated, and completeness is assessed. Two types of measure errors exported in registries are random and systemic errors. The former occurs by chance and cause inconsistency in repeated measures. On the other hand, systemic errors like instrument calibration, environmental challenges, and procedure changes introduce distortions in measured against the actual values. Selection and information bias affect the registries. Selection bias occurs from the procedures adopted to recruit subjects, and information bias may result from the error in measurement of a disease or exposure. Misclassification can cause inaccuracies or variation in methods of data acquiring or case exposure definitions. Changes in diagnostic procedure can affect the comparability of data, and variability may attenuate true associations in epidemiological studies. Passive or active surveillance methods are used to collect the data. In passive, the data is passed to the person for entry into the registry, and in active surveillance, the person involved in maintaining registries collect the data by phone calls, emails, visiting doctors and hospitals. The data is collected using a form, and information is obtained on genetic factors to establish genotype-phenotype correlations, family history, and medication details, medical or surgical interventions. In India, also, there are many types of registries functioning like birth defect registries, stroke registries, cancer registries, and transplant registries. Special surveillance studies. Special surveillance studies by various organizations like International Network of Pediatric Surveillance Units on molecular epidemiology of Rett syndrome, Prader-Willi syndrome, and Smith-Lemli-Opitz syndrome, the Surveillance, Epidemiology, and End Results program of National Cancer Institute on a number of uncommon cancers, Center for Disease Control and Prevention, programs on infectious diseases and birth defects, the Agency for Toxic Substances and Disease Registry on exposure to toxic substances, and the American Association of Poison Control Centers aggregates surveillance on a broad range of poisonings are also serve as a sources for estimation of prevalence of rare diseases. Biobanks may be defined as structure collecting biomaterial and associated data either for specific disorders or for a group of disorders. These biobanks collect biomaterial, process, catalog, and distribute the sample to the scientific community. There are two types of biobanks, that is population-based biobanks, which are like Estonian Genome Project, the Genetic Alliance Biobank, the National Rare Disease Biospecimen Resource, and disease specific, the examples of which are Eurobiobank, Central Research Infrastructure for Molecular Pathology, the Nubian Biobank Consortium, Telethon Genetic Biobank Network, Munich Tissue Culture Collection, Myobank AFM, DNA, and Cell Bank. The biobanks are funded by short-term research grant, patient organization, private donations, members and users. Samples along with information on disease with ICD, MIM and ORFA code will be supplied by the biobanks, which can be helpful in estimation of prevalence of rare diseases. Genetic tests. They are available for about 1700 diseases. Most of them are rare diseases caused by mutation in genes. The intended uses of genetic tests apart from estimation of prevalence of rare diseases includes providing information to the patient or family members, reduction of morbidity and mortality, and counseling for reproductive decision making. The methodological challenge encountered in genetic testing are lack of randomization trials and limited efficacy of tested interventions and low power reported in observational studies. The genetic test for a rare disease encompasses chromosomal, molecular or biochemical. The reported sensitivity and specificity of genetic tests were approximately 98.5% and 99%. Genetic tests recommend for rare diseases where identification will improve the clinical outcome and when there is evidence of family history and demonstrated evidence of disease. Newborn screening. Newborn screening, which is offering testing to the population, is one of the methods for estimating prevalence of rare diseases. Most of the tests used in screening rare diseases use biochemical methods, and only in case of confirmation, molecular testing is undertaken. Countries like United States, Canada, United Kingdom, Ireland, Canada, Germany, and Australia have official and mandatory programs for newborn screening for rare diseases. In India, there are government initiatives for newborn screening, though some individuals made efforts in this direction. The American College of Medical Genetics in 2005 proposed screening of 29 disorders, including rare, based on proved screen tests and efficacious treatment and adequate knowledge of natural history. Screening for cystic fibrosis carriers have been reported to decrease the number of US infants born with cystic fibrosis. Screening for beta thalassemia major at premarital, preconception or prenatal stages is done in various countries. Cascade screening. Cascade screening, which is the reflexive testing, is done in relatives affected with Mendelian or monogenic disorders, particularly in case of autosomal dominant disorders. Cascade screening has been shown to reduce the morbidity in the affected patients with familial hypercholesteremia in Netherlands. Cascade screening has been recommended for the relatives of colorectal cancer carrying mutations for Lynch syndrome. Carrier screening was recommended in USA to rule out uniparental disomy, that is, both disease alleles contributed by single parent, to inform reproductive decision making, to reduce the risk of breast and ovarian cancers in carriers of BRCA gene mutations by prophylactic surgery, and to reduce the incidence of colorectal cancer by surveillance colonoscopy. Let us sum up the module. Common diseases can be defined as those diseases which are prevalent in the community or country. Prevalence of common diseases is investigated using cross-sectional study designs. Therefore, commencing the study, aims of the study have to be defined. The disease condition and risk factor should also be clearly defined. The target population should be selected. Target population can also be defined based on the age, sex, language, ethnicity, income, and residency. Sample size can be calculated using either power-based approach or confidence interval width. Sampling unit can be individual, house or hospital. Sampling methods are of two types, non-random and random. The non-random method are classified again into three groups. They are purposive sampling, convenience sampling, and snowballing sampling. Random sampling methods can be categorized into simple random sampling, systematic random sampling, stratified random sampling, cluster random sampling, and multi-stage random sampling. Large non-response can mislead and represent only those who participated in the study. Incorrect assessment of association between an exposure and an effect in the target population is called bias and is of three types, such as the selection bias, information bias, and confounding bias. Odds ratio is used to assess the strength of association between putative risk factor and outcome. Prevalence estimates are expressed in percent for 1,000 people or 100,000 people. Prevalence data with confidence interval should be presented. The prevalence data can be A, standardized to country or world population, that's the standard population, to facilitate comparisons of prevalence estimates between population or across time periods. Different organizations and countries have defined the rare diseases using different cutoff number. European Union and European Medicine Agencies defines rare disease as those diseases occurring in the frequency of less than 5 in a population of 10,000. In Japan, occurring not more than 4 per 10,000, and in United States of America, 1 in a population of 200,000. It is estimated that about 6,000 to 8,000 rare diseases are known to exist. The prevalence of rare disease in European countries was reported as 6 to 8%. In India, the reported prevalence of rare diseases was 1 in 2,497 newborns. The twin problem confronting the research and management of rare diseases are lack of disease-specific code in international classification of diseases and clearly defined diagnostic criteria. Prevalence data in case of rare diseases are cost-effective, can be measured repeatedly, and the data is useful for a long period. Prevalence of rare diseases can be estimated for various sources like case reports, birth or death certificate, insurance claims, administrative database, patient registries, special surveillance studies, biobanks, genetic test registries, newborn and cascade screening programs. Thank you.